Yeah,
So funny.
just the thing, Brian. I have a heart out exactly at 2 o'clock. Okay.
Yeah, I have a heart out too. So let's get
Okay.
going, man.
All right.
Hello
All
and welcome
right.
back to the Low Carb MD podcast. We're streaming live and then we're also recording this for posterity's sake. Tro,
Uh,
welcome. We have a great
oh,
guest
oh my
who can
God.
deadlift more than both of us combined.
Actually, I think that's probably true. Somebody who can. I had the pleasure of meeting him. We have an awesome guest. Just let me give you a quick brief. First of all, he's got the greatest name. If I was going to see a psychiatrist, I'd want to see Dr. William Suave, right? Did I pronounce it right? Suave? Is it it's Suave, right?
No,
No, okay.
but that's a
Well,
great place to start. It's
yeah, perfect.
the A comes before the U, which I do maintain is an optical illusion for all English speakers. So it's Sauve because the A comes first, and that now I don't say it quite good enough for my cousins, but the closest you can get to the French name is Sauve.
Well, can we excuse my Armenian and my dyslexia? My Armenian heritage and my dyslexia.
You're
But
100% forgiven.
but I'm gonna call you Will if you're okay with that.
That's my favorite, actually.
Awesome. And I'm excited because we met. I think it was about a year ago, and I
Something
was
like that.
like, we were talking about metabolic health, and you were talking about metabolic psychiatry, and I didn't know. Actually, I knew you before then. I had been following you on social media,
Oh yeah?
and I was like, this is a cool guy. I'm gonna follow him. It happened to be you when I finally connected the dots, and you revealed your identity to me. But I'm excited to have you here. I know you're very interested in. Well, first of all, I know you served, so thank you for serving. One,
Thank you.
two. You, I believe you did your residency. Well, first of all, let's read off some of your accomplishments because I don't want to undercut you. You got your undergraduate in biology from Mercyhurst College,
Mhm.
and you did your residency. Was it at Walter Reed?
Yeah,
And
they call it the National Capital Consortium because it was Navy, Army, and Air Force combined.
and
So basically the whole capital area.
and you are board certified by the American Board of Psychiatry and Neurology, and
Mhm.
you have been the faculty at the Neuroscience Education Institute. And wow, I'm surprised to see this because this we could talk about. You're an active member. I don't know if this is still true, so we'll find out. A part of the American Psychiatric Association. So we'll still see if that's true. But we chatted, and I was like, we got to get you on the podcast. And I'm so happy that we finally did. Your passion for psychiatry and your passion for metabolic health moved me, and I'm so glad and so honored you took time out of your day to come here. And you are now currently the chief medical officer at OSMIND, which is a EMR that's looking to really help the clinical docs out there who are the front lines for mental health and particularly around metabolic psychiatry. So excited to have you.
Man, thank you
Did I
so
miss
much.
anything?
No, no, you didn't miss a thing. I was delighted to hear it. It's all extremely flattering.
So let's start with maybe there's so much that I want to talk about, and I know
Yeah.
Brian's probably wants to talk about it. There's been so many changes just in this week on the psychiatry front, with the HHS removing funding from the AMA and removing funding from the American Academy of Pediatrics, um, regarding some psychiatric conditions, which I thought was a welcome change. And the field of psychiatry has changed so much, and particularly around metabolic health. When Brian first opened up his mouth about metabolic health, and mental health, 7 years ago, he was asked to relinquish his board certification.
Mm.
He had doctors basically saying you're crazy. And let's fast forward over the past, several years. Now we have meta-analysis data showing that a ketogenic diet improves withdrawal symptoms in alcohol. Certainly, we knew seizures, migraines, and a new meta-analysis showing improvements in depression that was just published within the last three months. We have case series on bipolar, schizophrenia. So maybe you can just talk about your own medical career, how you started, how you got interested in psychiatry, and what brought you over to the dark side of being deplatformed and, being a conspiracy alt-think doc who turned out to be right, like Brian.
That's that's one heck of a question. It all started because I joined the Navy to go to medical school, right? And I only did that because I was afraid to take a loan from a bank. And my uncle had been in the Marines, right? So it's not some massive story of inspiration. It's just my dad looking at what medical school was going to cost, and he like pushes this pamphlet across the table. He's like, "Have you ever considered the Navy?" It's like, so we went down that route, but I went to the Uniform Services University. Have you ever heard of that place? It's a little known medical school, but think of it like going to one of the academies, except it's
Mhm.
medical school. So unlike, there's a scholarship in the military to go to medical school, but my school, you actually go to school in uniform every day. And it's not a scholarship. You're just on active duty, and school doesn't have tuition. So I went to this kind of oddly structured medical school where I was active duty in the Navy the entire time. And it was only after I graduated that I realized this, but you're really in the active duty medical school, they kind of train us like it was the 50s, in my opinion. So unlike modern doctors, we all kind of talk about how I think modern medical school is really designed to make employees, right? Not really like independent doctors. But in military medical school, they recognize right from day one that I, as a Navy physician, could wind up all alone on a ship. And so they have to teach me how to be independent. And so to this day, I think I was trained from day one by the Navy, starting in 1996 to think in terms of maybe being all alone. I could be way out in the middle of the desert with thousands of Marines, which actually happened. I could be on a ship all by myself. And you have to think like that old school physician where you rely on your knowledge, what you can do. You're not practicing checkbox medicine. And then like fast forward to residency, it was the same kind of thing. Another just amazing coincidence, but I started residency in 2000. In 2001, we were standing in the morning report room on the fifth floor of Walter Reed watching the smoke come up from the Pentagon. So it's like I'm in my residency in uniform in my second year when I had chosen psychiatry, which was completely by accident. Like, so in answer to your question of how I fell into psychiatry, it was my first third year medical school rotation that I didn't hate. So I'm like, wow, I like this kind of work. And it was the first time that one of my teachers actually sat me down and said, I think you're kind of good at this, kid. And it's like, well, that's the first nice thing anybody ever said to me in medical school. So naturally I like bonded. It's like this, I'm going to do this forever. So here we are, second year, and all of us in uniform watching the smoke come up, and it's like, well, we're going to war. Like this whole military thing has just become very real. Because at the time that I started school, we were in the long, like what, 30-year plus period. There were people that were on active duty, while I was in, who did a full 30-year career and never went to combat ever. Like that was very normal. And then in 2001, that just completely changed. By 2003, the residents were running the hospital because all of our attendings were deployed into combat.
Mhm.
And when I graduated, they gave us all medals for that. So I'm a sailor, and I have an Army Commendation Medal on my uniform because Walter Reed gave us medals for running the hospital when we were residents. So it was like this whole interesting backwards thing. Then I graduated in 2004, which means I went straight to combat. So that was actually my fellowship. So I'm like, and it's also like a little known fact that they don't really put psychiatrists on ships, mainly because there aren't enough of us. There's 90 and change psychiatrists in the Navy at any given moment. if you put a psychiatrist on a ship, you lose that psychiatrist for like 9+ months. And the one ship is not enough to do for a psychiatrist. It's like even a carrier is maybe 5,000 people, most of whom are allegedly relatively healthy. So the psychiatrist is going to be bored and completely unavailable. So they don't use us that way, but they will send us out with Marines because you're land-based and you can have a much larger population. And that's what they did when I graduated. I was the one like young single guy in my class. So immediately to the middle of the Al Anbar province in Iraq with the 7th Marine Regiment, where I worked for the colonel. And that was like 2 years of my life. So I tell people that was my fellowship, that I was out in the desert with a infantry unit with combined arms and working for the colonel. So seeing patients naturally, but also kind of consulting to the entire unit from a mental health point of view and like learning that like in combat acute stress disorders, and you could kind of think of it like disaster psychiatry. Then when I came home, I went to San Diego, and that was where, I did inpatient psychiatry, electroconvulsive therapy. I had the disaster team because we have a disaster team at every one of the major naval medical centers. So the one in San Diego was mine. So the background there is that there's only one kind of psychiatry that I've actively avoided my entire life, which is sitting behind a desk writing scripts 4 times an hour. So, in answer to your question, that's how I got my attitude that you've noticed and my interest in metabolic psychiatry, because my interest in interventional psychiatry, and in other words, my interest in any kind of psychiatry that doesn't involve just giving out scripts over and over and over and over, and people not really getting much better and leading to incidents like you and I were, just talking about the other day, Tro.
Do you think, like, did you wholeheartedly buy? Because I know I did in medical school, the neurotransmitter theory of metabolic dysfunction, or was there some part of you that was like, doesn't, not everything's explained here? I mean, and that's tough, because I don't think I had a thought. I just bought it, right? Even though I think now we know a little bit better, right? The involvement of the microbiomes, ketones, diet, all these things are the chinks in the armor are coming out. But back then you're like, you're serving the military, you're people who need mental health the most, and the tools that you have are basically drugs. So I like, what was it like to be in your head back then, and how you're serving your patients?
What it was like to be in my head.
Yeah,
Like
what? How did you think of disease? How did you think of how you can help them? Like, how did like, what?
Well, plus you're stepping into a situation where you have 30 years of peace, so now no one's really trained and dealt with what you're dealing with, right?
yeah,
This like you're kind of on the frontier also.
it's funny you say that, and I'll get back to your question, Tro, because that's something that's been bothering me for a really long time. It's really interesting that you asked me that exact thing. But going into combat with the Marines in 2004, like not only were we dealing with a force that had not seen war like in a couple generations, but this notion of embedding psychiatrists that deep in a Marine Corps unit was a brand new job. So when I graduated and they sent me to that job, one of my attendings, who was actually the guy in charge of the disaster team at Bethesda, he gives me this book called Achilles in Vietnam, which you should totally read, and it'll take you like 5 minutes. And you've never read a better book about PTSD and more the meaning of PTSD as opposed to just like the nuts and bolts and amygdala of PTSD. But he hands me this book, and he wrote in the front of it, it's like, this is the closest thing you're going to have to a textbook for the job you're about to do. Was
Wow.
that he's like, this is new. Like, no one's really done this. We haven't had psychiatrists this far out in the field. We sure as heck don't know how to teach a psychiatrist how to get along with 15,000 Marines, and that the whole thing. So it was really like a totally new adventure, which is exactly what I enjoy. So I was kind of the luckiest kid in the world at the time that I graduated to do that. But that also speaks to your question, Tro. In medical school and definitely in residency in 2004, not only did I not 100% buy the chemical imbalance, right? Like, neurotransmitters are real, though. I mean, if I never hear the words dopamine, serotonin, norepinephrine again for the rest of my life, it'll be too soon because I'm so bored with that. It's like, in my opinion, it's just kind of played out, but they're real. But this whole depression is a chemical imbalance thing, I was literally taught, and I'm pretty sure I answered correctly on the test during my residency, that that had been debunked. Like, so by like 2001, 2002, nobody in my training program believed that that was a thing. And we'd been taught by our professors that isn't a thing. And actually, I was taught in residency that the only reason anybody ever thought this whole neurotransmitter monoamine hypothesis of depression was because drugs that increase the activity of the monoamines seem to help with depression. So somebody basically reasoned backwards, right? They're like, I give the drug, it makes the serotonin more, and at least 30-ish% of the patients feel better because that's actually the success record of most of the like SSRIs and SNRIs. They're like, ergo, this must be an illness of somehow not having enough serotonin. Well, I was hazed to within an inch of my life in first year medical school for saying something like that. I mean, I always knew that's the opposite of science, right? First year medical school, we're doing some of our like case reports and our group projects. And, we said the patient's sick and someone said, give him penicillin. And in the role playing game, our attending is like, all right, the patient starts to feel a little bit better. And then says, like, all right, Ensign Sove, what do you think's happening? I'm like, well, he must have had an infection because penicillin made him better. And then I almost blacked out from the hazing because they're like, that is not how science works. It's like that. And yet, it isn't the whole monoamine hypothesis was based on that. So to your point, I always knew that was wrong because I wasn't allowed to talk that way in medical school. But again, I was taught that this whole monoamine thing was debunked when I was a resident. So I haven't thought that for 20 years. Yet there was an article, I think, in The Guardian or something like 2 years ago that someone was so excited to tell the world that they believed that the monoamine hypothesis had been disproved and that it's this big expose that, it's not really a serotonin deficiency that causes depression. And I'm like, wait, I people didn't know that because I was under the impression that that was a known fact for like greater than 2 decades. But I'm coming across young psychiatrists now who swear to me that they were taught in residency that the monoamine hypothesis, depression is a chemical imbalance. So it's weird. Like you alluded to conspiracy theories. That's one of my conspiracy theories. Like, how does this like myth of the chemical imbalance thing just continue to survive? And why do people keep teaching that?
I want to like talk about this because there's a lot of myths in medicine, and I feel like
Yeah.
in the past 1 year, we're finally tackling them. Vaccines, nutrition. I don't mean to be inflammatory, but I'm just going to say gender affirming care. Conflicts in medicine. All of these things are becoming, attacked, and I wonder like how did we get here? Right. And I think back,
Yeah.
and Brian, I think I mentioned this to you, and I think back to, Semmelweis, right?
Yeah.
Imagine being Semmelweis and seeing that, hey, when you wash your hands, wash the instruments, people are living, longer and better, and they're doing better. And imagine going to the Council of Idiots, right, and saying, hey, there's this invisible thing that goes away when you wash your hands, and I just want you to believe me because I'm doing better than you. Right? Even though it's complete truth. It was the truth.
Mm-hmm.
And he went to them, and of course the response would be like, they probably called him a conspiracy theorist.
Probably.
Right?
They didn't have
And
that term yet,
did.
but yeah, they
And
said he was crazy. He went to a psych
committing
ward.
suicide.
Yeah.
Yeah, he
Well,
ended up committing suicide.
and
'Cause
that's
he
the
was,
thing is they don't give us primary care frontline docs. They go, we know what we're seeing. Like when we say we know what we're seeing with whatever you want to call it, with the lockdowns, call it whatever you want. We know what we're seeing. And so when we saw people were treating their diabetes and all of a sudden their bipolar's better, their depression's better, they're enjoying life more and they're laughing, you go, wow, that's like you can't unsee that. So when we made that observation, we're seeing this in our practice. The doctors were the ones who attacked us and said we were crazy for saying this. It's unbelievable, but that's what we're seeing. It's documented. You want to see the charts. So it's frustrating when like those kind of things. I remember watching Pierre Corey saying, "Hey, look, I'm in the ICU and I'm putting people on high dose steroids, and they're walking away and they're not going on the ventilator." He's crying before Congress, telling them, "Please." And I go, "Well, we don't have enough funding to look at that yet." You know what I mean? When you're in the middle of something, you go, "It's working. I'm telling you, what's working." We don't need randomized controlled trials sometimes to like if you're in a life and death situation, you have terminal cancer, you maybe try different things.
Yeah, they're I mean, number one, I agree. It's just all been very weird, right? It's like because I've watched the same thing. It's like a doctor does a thing and the patient gets better. And then there's this weird attitude, like nobody wants to hear it. And it's very, very strange. There may be some, again, going back to being in the Navy, everybody used to say when I got my orders to go to the Marines, which was out in California, they're like, I was so miserable when I was training in the DC area. And everyone said I was going to be so happy when I got out to California. And I'm like, you think that because I'm 6'3" and you think I'm really going to take to surfing? Like, what's going on here? And finally, they got it across to me that when I was in 29 Palms with the Marines, they are very, very what we call goal oriented. Whereas my entire existence in Bethesda was what we call process oriented. And honestly, when you are that close to the capital and in training, I started to feel like you could cure cancer in your basement and then bring the report of what you did to the hospital, and the admiral will kick it back to you because the folder it was in was the wrong color. They're just like, well, good for you,
Hmm.
but we really need you to follow this process and
Hmm.
put the cover sheet on your TPS reports, or we're not really going to be able to look at this. Meanwhile, when I was with the Marines for those 2 glorious years, the colonel would ask me to solve a problem and I would go solve it. And then I would come back to the colonel. And if I started to tell him how I solved it, I swear he would start to reach for his weapon. It was just this completely different. He's like, Lieutenant, is it fixed? Yes, sir. He's like, good. Well, I'll see you at chow. It's like all they cared about was that we were fixing problems, fixing patients, don't really want to know the details, just get it done, keep doing what you're doing. So totally different universe. And I realize now how wonderful it was. That's also probably what gave me my increasingly terrible attitude and why I just completely jumped on, metabolic psychiatry the minute that I saw some of those first lectures from Dr. Palmer and saw things going on at conferences with you guys. And it's like you did miss one thing, by the way, in my list of accomplishments. I'm actually a double major, biology and biochem. So when people ask like why I as a physician think that, I have any business talking about nutrition, and I'm like, because I'm a biochemist. It's like number one, I can read, which is apparently somewhat unique among our colleagues. But number two, it's like, yeah, I got a biochemistry background. It's like we can 100% talk about the Krebs cycle and nutrition all day long. And the minute you learn what insulin resistance does to the brain, like I just don't know how it could be any more obvious.
Brian, I told you you'd like him. I
Yeah, I
told you
mean,
you'd
you
like him.
observe and you see what works and what doesn't work, and that's
Yes.
what's frustrating. When someone says, "Here's what's working," like I was just watching government testimony. This guy is saying that you were talking about he's a vax expert. He doesn't know what mRNA is and all these. He had no clue, and he's from Stanford. Anyways, the point was this guy goes, "I lost 100 patients in the first month to COVID." I was like, "Well, hell, I lost zero. Shouldn't I be making the guidelines?" Like you're the one
Right.
making the guidelines for everyone. Like the guy who crashes the plane all the time. You want someone who's not crashing the plane to
Let's
teach
just
the
put
guys?
our records up on the wall and then
It's just
see who you
wild
should
though.
be
It's just
talking
wild when
to.
you hear that stuff. And from your, for me, think of psychiatry. I think it's the most intimate area of medicine, right? It is the toughest area of medicine, I think. But it's become totally impersonal. Like when I talk to patients, hey, how's your psychiatrist? They go, he doesn't talk to me. He just says, are you having side effects? Are you having this? Okay, let's go up on the dose. But I'm feeling sick every day. Oh, we'll double the dose, then you'll feel better. I mean, there's no talking about what's going on underneath. It's like life has no, it's the drug that needs to be adjusted, not let's look at how your life's running type thing. And they go, well, they just sent me to the psychologist for that.
Right, right. And this also goes back to like being a classically trained psychiatrist. So you'll forgive me if I start sounding all psychoanalytic
Hmm.
when you ask me questions, but I actually was trained that way. To be the kind of psychiatrist who is intimate, like what you said, that's terrifying. So you can, I mean, there was a wonderful story that we got a lecture from a suicidologist, which was you can imagine what an exciting lecture that was when I was at
Mm.
Bethesda. But one of the anecdotes he told us, in his like clinical experience and studying suicide, he had a patient who had had suicidal ideations and they were very brittle and a high risk kind of patient. And this goes on for I don't know how many months or years. And finally, one day, this young doctor asked the patient, like, tell me why you're still alive. It's been very frightening. You
Mm.
continue to have suicidal thoughts, and yet somehow you've not killed yourself, which is wonderful news. But tell me how we got here. And the person like looked him right in the eye and basically said, well, all this time I'm so interested in the therapy. I always want to know what happens next week. And of course, I couldn't bear to disappoint you. And this guy looks at us and we're all kind of wide-eyed. He's like, "Yeah, that was the most terrifying thing I ever heard in my entire life." Because he realized like you're not this person's not alive because of your amazing skill. This person's not alive because you knew like what pill to give them. This person's alive because of something in you that you kind of can't control and it's abstract and you don't really know how to reproduce it. So you have to like go to work every day and be that intimate with people and be that messy and realize that it's all kind of like going by feel and you're trying to help people feel better and you don't really know what's going to happen. Imagine the temptation for all those young doctors, like ever since the monoamine hypothesis, that I can just be right all the time as long as I read the physician's desk reference and know which pill to give out. Like that is an infinitely less terrifying way to practice medicine.
Hmm.
And then it's like,
Protocols.
and then if you, oh yeah, if I have a computer that's covered up in checks boxes, even better, right? It's like I can, as long as I check the box and I give the pill and I do the thing, and then we see somebody 4 times an hour, so the admin doesn't give me any crap, and you make a pretty good living, and we can all, go along our day. Now, no one's getting better, but that wasn't really one of the conditions for victory, was it? I mean, up until maybe the first year that I was on my inpatient unit at Naval Medical Center in San Diego, frankly, all the medications, they have about a 30 to 35-ish% success rate, and that's all there is. So you're kind of in this situation where if you're dealing with depression, 70, half to 70% of your patients are going to get maybe less bad, but not well. And that's just how it is. And in like '06, '07, I think that's when aripiprazole was approved as an augmentation drug. And that's the first time we ever had something like that. And on my inpatient unit, like the day that I heard about that, I looked at my residents and said, there is no excuse anymore not to go for remission because we have this additional tool. Of course, I was the jerk that I was sending people to ECT first line. So naturally, I was going to blurt something like that out once I had a tool where I could take someone with, partial response on an antidepressant pill and then add this somewhat novel, antipsychotic class drug, and there'd be a greater chance of them getting into remission. But the whole field kind of continues to just live in this space where we just give drug after drug after drug after drug and pretend that we're okay with the fact that people are getting like less bad, but they're not really getting better. And then you got me ranting again, but Brian, that's to kind of go back to your original point. I also think that's just, well, for most people, that's a much more comfortable way to practice. I mean, it's kind of hopeless and helpless, but you do it every day and you're not scared and you kind of make your living and it's 9 to 5 and that's just all there is to it.
Yeah, I think Tro and I can really identify because when you're talking about this, we're looking at diabetes, and
Right,
it
right,
was
right,
just
right.
like,
Same
here's what's going
thing.
to happen.
Same thing.
You knew the story. You're going to get, you're going to start getting vision problems. You're going to get depressed. You're going to get foot ulcers that don't heal. Then you're going to get an amputation. You just know the story, and we're
Hmm.
just saying, let's just try to keep those sugars under control as best we can,
Yeah,
and so once we
just
started saying, hey,
manage
we
it.
can reverse this, like we can reverse this, and then it's controversial. It's like, really? It's like, it's crazy, especially when you see what the standard of care is. You go, the standard of care sucks. It's bad, And they just expect here's what it happens in it, but then you go, here's the next drug on the protocol. Then you just add this, and then you're gonna add this, and then you get a diabetes educator, the sugars get higher, they get more insulin, and then it's just a crazy story.
It's a crazy story, but yeah, it happens in my field too. I mean, I've been doing transcranial magnetic stimulation for 15 years. And for 15 years, the average patient with depression that comes to me for TMS has had 8 medication trials.
This TMS,
Eight.
do you see improvement?
Oh, like you wouldn't believe. That's why it's been my favorite thing for 15 years. And
Wow, yeah.
which is also crazy to me. I mean, speaking of, our thoughts about metabolics, but TMS was FDA approved for depression in 2008. And I mean, the only reason I got my hands on it was I was still in the Navy and I was at the Naval Medical Center in San Diego. So the medical center has to buy the coolest, newest stuff because it's the Naval Medical Center San Diego. The Admiral is a hematologist, right? It's like she wonderful. I loved working for Admiral Hunter, but obviously she didn't know what that thing was that she just bought. And then I was the ECT guy, I was the inpatient guy. I'm pretty sure someone told the admiral it was electrical, and she said, then give that crap to Will. Like that's exactly
Hmm.
how that thing would have gone. So I get my TMS machine and I immediately fall in love because if there's nothing I love more than electricity. Like it's not an accident that most of my childhood mishaps involved electricity. And I took out the entire house multiple times when I was a kid. Thank heavens my dad knew how to fix it. But once I had TMS, and I was coming from inpatient psych where I had the drugs with about a 30% success rate, and then a vast desert of nothing, right? Like no tools in psychiatry until ECT, which is, 80 to 90% success rate in depression. Like it is the king, undefeated for like 8 to 9 decades in depression. But I got nothing in between. Once I had TMS in 2010, I suddenly had an intervention that is successful a good 2/3 of the time. And I've seen that be stable across like 15 years of practicing TMS. And at this point, I've treated more than 2,200 patients. And I think I might hold kind of the unofficial record, actually, just like being one of the most prolific TMS guys in the country. But don't quote me on that because it's unofficial, but I'm kind of close to the top. And across the board, 65 to 70% of my patients get substantially improved. A good 30 to 40% of them get remission. And not only do they get remission, but when people get remission from TMS and depression, it's pretty common for them to stay well for a year or more. And you can repeat the treatment, but in general, you're going to do a treatment that, as it is now, it's about 6 weeks worth of having a 20-minute treatment every day. And then when you're well, you're well. And there isn't really a maintenance or particular follow-up protocol until or unless the depression starts to come back. So like effective, but like also kind of a game changer in the way you approach depression. Because just like diabetes, you're not just managing the decline anymore. You're actually getting people into remission and then, working to see if you can keep them well.
Yeah, it's amazing. Yeah,
Yeah.
without the side effects of the ECT, right? The possible side effects. And then
Yeah.
I've been using it in my practice. I've been really amazed for anxiety, PTSD,
You've been
sleep.
using TMS?
I have no financial interest in it, but a product called Alpha Stem.
Oh yeah, 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 yeah. Yeah, Alpha Stem massively popular on the military side. So
Yeah, there.
especially when I was on active duty, like I mean, there wasn't a unit that wouldn't buy one of those things for an active duty person. That's a super interesting technology, right? The cranial electric stimulation. But
And you're using the more high tech version of that.
it's more high tech. It's just, instead of stimulating like alpha stim,
Yeah.
where you put about 2 milliamperes on the ears, and the fact that you can reach like down through the vagus nerve and like get up indirectly through the trigeminal, it's all wonderful. And that I mean that stuff has actually been done since the 70s, and there's that flow neuroscience. They just got an FDA approval for a TDCS device, right? A little different than your alpha stim, but that's just basic 2 milliamperes right to the face, where the anode is over the left dorsolateral prefrontal cortex, and they believe that it's greater than nothing in depression. TMS is like I don't even know if you call it more high tech per se, but instead of 2 milliamperes right on the skin, it's about 1.5 to 2 Tesla electromagnetic field that will induce current in the neurons while completely ignoring your skull, right? Because that's the problem with stimulating right on the surface is that your skull is just a wonderful insulator.
Yeah.
That's the hard part about ECT too. It's like when you're doing ECT on people, 90% of the current off those paddles is being shunted around the scalp. So all of like the thunder and glory of ECT is so that you can get a trickle into the brain,
Mm.
right? Just enough to cause a seizure so that it's therapeutic. But TMS, the power of magnetism, you can ignore all that. And that's why with TMS, you can stimulate neurons and make someone's thumb move, which, interestingly, most of my patients find hilarious. I do usually get them to hold their hand in front of their face. I'm like, see, I'm doing it. And we
Yeah.
can wiggle their hand around.
So are you're combining that with metabolic
When I
approaches?
can, it's and then in my current position at Osmind, I have grand plans to do that a lot more. So in my previous work at a TMS center that I kind of started, right about 11 years ago, I founded Virginia Interventional Psychiatry in Richmond. And that was a TMS dedicated center because I believed that if someone didn't focus on TMS, it was never going to happen kind of thing. And that grew into this big, we peaked at like 200 centers in 35 states, ultimately, like doing TMS all over the country. Most of the time, up until I left that company in 2024, I could get some of my patients to follow my metabolic recommendations so that we could combine it with TMS. But for the most part, I just kind of got angry complaints. And to your to your point about being deplatformed, and it's like, yeah, I got a couple official complaints up the chain at the TMS company that they wanted me to stop talking about all that diet stuff and just do TMS like a good little boy.
Well,
Now
yeah.
in Osmind, I'm having the opportunity to write some protocols, and where the psychiatric interventional psychiatry focused EHR, we get 800 clinics in 49 states. It's just a coincidence that we don't have a customer in West Virginia, but soon enough, we'll be in all 50. And with our network and our support, I mean, we build templates into our system, obviously, to facilitate TMS. We built the REMS program for esketamine into our system so that anybody that is on the Osmind network that does esketamine treatments, they don't have to do everything twice the way everybody else does because of the way the REMS, because we do that auto magically. But another one of the opportunities that is like right in front of me is to actually start writing treatment protocols and giving clinical suggestions, clinical guidance to some real badass interventional practitioners out there who can start like really combining metabolic psych with TMS. And you read my mind. I mean, I think TMS is basically like putting your brain on a treadmill, right? We make the neurons fire 10 times a second, 3,000 times in 20 minutes for one treatment. That is not metabolically free. And I can think of no better way to optimize that treatment than to have a head full of ketones. So,
Yeah, well, and I'm looking from a slightly different perspective, but we're saying like you see the benefit of those things together. And so for us, Tro and I have said it for years, is the biggest downfall to what we're trying to do: life stress, lack of family support, depression. If people are depressed, like right now, I talked to people, I was depressed and anxious, so I went and had chocolate. You go,
yeah,
what
yeah,
if I
yeah.
can calm that anxiety component of this thing down where you don't need that as your drug of choice? Can we intervene better? Obviously because I remember back in you guys may know this study, but there was a study they did with Celebrex, and they were showing that people on Celebrex had less depression than people who weren't on Celebrex. And I go, well, but
Inflammation.
yeah, and they control for the pain level, and they go, no, they still had pain 7, but they dealt with it better. And you go, inflammation in the brain. Now I get it, but at the time I'm like, that's a dumb study. Why are they even looking at depression with an anti-inflammatory? And then we talk about, metformin improving fibromyalgia, and you go, why would that be? Well, maybe it's just chronic inflammation going on. So
Yeah.
it is really intriguing. So you go, well, if I'm trying to get the brain better, decreasing inflammation, then also getting the brain to function
Yep.
uh, at a higher level metabolically, it's very, it's a perfect combination.
I think it's a perfect combination. I think I mean, everybody talks about durability, when it comes to TMS. They talk about durability when it comes to ketamine and S-ketamine are currently the only two like truly interventional procedures, right, in psychiatry are ketamine, S-ketamine, and TMS. And then we may have psychedelics to come. And everyone keeps talking about durability. People are disappointed in ketamine because like ketamine can get you feeling better very, very quickly. But you basically have to, the vast majority of patients with depression, they have to have ketamine every week, every couple of weeks. Like you can't stop or they're not going to stay well. With TMS, if someone has recurrent depression, it's like you can get them well and they might be well for a year, they might be well for 2, 3 years. But if they have recurrent depression, they're going to get depressed again. And it isn't because TMS wore off, it's because they got depressed again, because that's how recurrent depression goes.
Mhm.
But to your point, do they have recurrent depression because they have smoldering inflammation, which is pushing their brain towards depression all the time? And every once in a while, I can snap them out of that with something like TMS, but then the whole inflammatory process starts again, or the insulin resistance process starts again, right? The cognitive impairment process of insulin resistance all starts again. So they're just gonna get depressed again. So is it possible then that if I could resolve their insulin resistance, resolve their inflammation, using something like a ketogenic diet, which, I'm a huge fan, obviously, I snap them out of their current episode with TMS. It's like, are we going to start seeing sustained remissions? Like people who get well and stay well for years and years and years on end, which right now is also unheard of in psychiatry.
I think one of the things that you just said it's really unheard of getting people well, and going back to what you said earlier, which I've wanted to sort of chime in here, which is that there's a huge disenfranchisement, right? Like amongst the physicians that are out there, they I don't want to say it's intellectually lazy, but you mentioned that it's easier to just not care, right? Like,
Mhm.
you mentioned this unexplained, ambiguous part of a clinician that may be the saving factor here. Maybe a bit of curiosity, maybe a bit of empathy, maybe connection, human connection is this ambiguous part. And I think that's what leads people just down these rabbit holes. Like, why would you find TMS? Why would you look at as ketamine? You would only. Why would you think about a ketogenic diet? It would have to be either you observed something and you're curious about it, or you wanted something more and better for that person, and so you're searching, right? And I think most docs out there are just they're just tired,
Oh yeah.
right? They're tired, maybe a little lazy, and maybe afraid. Like they're afraid. You mentioned being afraid, right?
Oh heck yes.
And it's
Well,
easier to just write a script and pretend that was the right thing,
mhm.
you know. And it doesn't mean that it can't be the right thing. It may be that a script is appropriate, But I think there's something alluring about, this is off me. It's not my responsibility. Here's a script. Go. And I think that locked in and locks in these physicians, and like here you are, like still learning years later, like after your training, and you're finding each of these little things, and it's helping to cause like remission. And now that like we see the data, there's
Mhm.
data on esketamine, there's data on TMS, like there's data coming out on ketogenic therapies, and I wonder, do you think, because I know you work and talking to other psychiatrists every day. Do you think we're hitting a pivot point, like a point where maybe we're getting a critical mass that we're going to awaken? People talk about the Great Awakening, where we're going to awaken this profession up a little bit, that they should do better and we can do better. Or what are your thoughts about that? You're facing these docs every day, right? I mean, I'm assuming you talk to doctors every day, right?
Pretty
With
much.
Osmind, right?
Yeah.
What is the
And
sentiment out there, that you see?
I think you're 100% correct. We're like this close to an inflection point. And this is the like what some of us are calling it. And maybe when I say some of us, I mean me, but but a couple other friends. we're this close to calling it interventional psychiatry and starting to behave as though that's a subspecialty. But we're finally coming into a time when the APA, it's like, you asked me if I was still a member, I still am. It's like, yeah, yeah, and I've said some spicy things, in the at the meetings, and I actually went to my very first APA meeting in over a decade this year because now that like coming into this position at Osmine Chief Medical Officer, I'm like, I got to stop pouting and I have to start like going to the meetings and acting like a grown up and kind of doing the leadership thing again instead of just like putting my head down, treating patients and being angry all the time. And that's been fun. But this year at the APA, first time ever that I saw a broad acknowledgement of TMS at the APA. Like the APA has been pretty much ignoring transcranial magnetic stimulation for a decade and a half. And then this year, they're all kind of acting like, look at this newfangled, wonderful thing. And I'm like, all right, I don't know where you jerks are
Yeah.
going, but it's like I'm glad to see you coming into it. And they're interested in esketamine. And the truth is that right now, I'm going to estimate that 90% of psychiatrists, which is like 45,000, there's about 45,000 psychiatrists in the United States, and then maybe about 20,000 more psych NPs. So you could say between 60 and 70,000 like prescribing psychiatry practitioners, and 90-ish% of that number are not intervention capable, which means pretty much their entire business model is still showing up to work and just writing scripts all day. And they just don't like they don't have another tool in their toolbox. And it sounds cheesy, but I would chalk up everything you astutely just said, Tro, to kind of learned helplessness. Like all I have is a hammer. So I'm going to come to work and I'm going to pound nails all day. And what happens, happens. They're kind of, and
And
I get
30%
paid
of the
for
time
that.
it'll work.
But we are having these conversations at Osmind, where we were always an interventional company. Osmind was founded in 2020 to serve the ketamine clinics. And then that turned into the ketamine, S-ketamine, and TMS clinics. And we serve, general medication management too, but we're heavily skewed towards the interventional side. It isn't just, I think, helping my colleagues understand that you're going to get people better, right? You're like, this can finally happen. You're going to come. I told a guy the other day who's starting a TMS program, I'm like, you're going to hit home runs every day. That's where you can have this now. It's like you can come to work, you can see remissions every day, you can see people getting better every day and have that experience of winning every day, which you haven't been able to have before. The other side of that we're trying to help colleagues understand, and some of the really smart ones are really getting it. If you only write scripts all day long, you are a doctor who sells your time in 15-minute increments, and that's it. That's literally right. Like you don't get paid to sell the drugs. It's like we're the only drug dealers in the world who don't get a cut. So it's like that. No matter how many drugs I
Well, so
sell,
there's
no
a lot
matter,
of people getting cuts, right? So
yeah, but not us. And
yeah.
that so
Well,
you're
we
trapped
have
in this.
values, right? So like, but there
Correct.
are many doctors getting cuts,
But
right?
here, here's a psychiatrist, you're stuck selling your time and you have a ceiling. It's like a psychiatrist who's practicing that way. You can make decent money, but you'll never, ever, ever break out of that because you'll never have more time. I mean, you're just going to keep selling your time until one day you run out and you're dead. But when a
Mhm.
psychiatrist and a psych NP can learn to really do interventional, and you can leverage the power of TMS in getting people well, and you can leverage the power of esketamine in getting people well. But I, by myself in a clinic, I can run 2 TMS chairs and I can run 6 esketamine chairs and still have enough time to go do a good job. And the number of people that I can serve, and therefore the amount of value I can provide, is like easily 4 or 5x what I can do if I'm just writing scripts all day. So not only can I get people better, which is precisely why we all got into this business because it's just so amazing to get people well, but I can also like force multiply is what we call it in the military, right? I can 3x, 4x, 5x my productivity. So I can not just get people well, I can get many, many times the number of people well. And
What's
then
the
of course,
barrier? What's the barrier to TMS like not being used by the other 95%?
One of them is the equipment. That's always
The
been a huge
cost.
problem. Like, well, because a psychiatrist, we can basically set up shop with an office and a phone. And then if I want to really, really be fancy, I can have someone answering the phones for me. Like,
Hmm.
so when you ask a psychiatrist about their overhead, they think in terms of like a few thou a month. Like
Hmm.
that's kind of what we are. You go to a psychiatrist in 2010 and say, I want you to try TMS. And they're like, okay, what do I do? We're like, well, you buy this device that costs 100,000 and they throw up on your shoes. Like, it's
Hmm.
just like,
Yeah,
wow.
yeah. They're like, yeah,
Yeah.
no thanks.
Oh,
Yeah.
yeah. And you go to a radiologist and say 100,000 and they're like, what, am I buying 10? Like, what do you, but it's like,
Hmm.
but psychiatrists think different. It's like, I
Yeah,
get
yeah,
that.
totally.
So the inventory is really hard. So there is this whole like how you run a business thing that is like a huge, huge change for psychiatrists to think about interventional. There is also this like you treat patients and they get well and then you don't really see them anymore. So that if all I do is write scripts all day,